Welcome to this IAS-USA webinar. Today is Tuesday, April 26, 2022. My name is Jose Francisco, and I am a project manager at IAS-USA. We are delighted to welcome Dr. Matthew J. Feinstein, Assistant Professor of Medicine at Northwestern University Feinberg School of Medicine, who will be presenting on cardiovascular complications in people with HIV. Welcome, Dr. Feinstein.
Thank you. Thanks for having me, and thank you to everyone for attending. I look forward to this talk, and just as much as this talk, I look forward to hearing from everyone and getting into some of the Q&A. So first, I'll go through some housekeeping slides related to the webinar. These are the folks with the IAS-USA who have helped put this all together, and their financial relationships and disclosures. These are mine, and also disclosures of planners and reviewers. So regarding CME information, this is the IAS-USA is accredited as shown here, and this is a designated live activity worth a maximum of 1.5 credits. So obviously you should only claim credit relative to your participation in the activity. So it's also been approved for this type of credit, and there's instructions on the IAS-USA website for this. Finally, this is some of the grant support from IAS-USA for this. And the last point is the recording and slides from this, where they'll be available, and within 24 hours, they'll be available at the IAS-USA website on demand. So please feel free to refer back to it, to share with your friends who are also signed up or otherwise. We'll have some poll questions. There's some instructions on how to submit the questions. Specifically, we ask that you use the Q&A button on the Zoom. The goal is to address the questions in the time allotted, and certainly to address the questions during the Q&A afterwards. I'll probably get to a lot of them in the presentation. I saw some pre-registration questions that that are addressed by the slides, but I'm sure there will be even more questions that arise during the course of this, and we'll have plenty of time for Q&A afterwards to get to those. Okay, so now the fun part. I'm excited to talk to you all today about cardiovascular complications in people with HIV. And really what this is meant to be practical. It's meant to have some discussion of the underlying pathophysiology and some mechanistic points related to some of the research I do and research others do. But a lot of it too will be how do we use new and emerging knowledge, and really some of this emerging knowledge on cardiovascular complications of people with HIV to inform our day-to-day care of people with HIV to prevent and treat heart disease. So a few objectives. One is just at a high level to be able to describe and understand the epidemiology of cardiovascular diseases in people with HIV, but also along those lines to understand the risk factors for developing cardiovascular diseases, and then ultimately to think about patient-centered ways that we can prevent, manage, and treat cardiovascular diseases in people with HIV. So first, a couple of pre-test questions, which now have been brought up for you all, and each of you will have a chance to submit. So question number one is, how does the risk for heart failure among people with HIV compare to people without HIV? Answer one is heart failure risks are lower among people with HIV. Two is heart failure risks are approximately the same for people with HIV and HIV uninfected individuals. Three is heart failure risks are approximately 1.5-fold higher for people with HIV than for people without HIV. And four is heart failure risks are approximately 10-fold higher for people with HIV than for people without HIV. So we'll leave this up for now. And Jose, if you can jump in and just let me know when we should skip ahead to the next question. I'll give everyone a few seconds now.
All right, so Dr. Feinstein, we are now broadcasting the results, and we can move on to the next slide.
Great. The next slide is this one. So which of the following is true related to the immunopathogenesis of HIV-related atherosclerotic cardiovascular diseases? Option 1 is residual immune activation despite effective viral suppression with ART is implicated in HIV-related ASCVD. Again, ASCVD is atherosclerotic cardiovascular disease. 2, co-infection and viral reactivation can trigger chronic inflammation, but do not play an important role in HIV-related ASCVD pathogenesis. 3 is traditional ASCVD risk factors such as hypertension and smoking are not important contributors to HIV-related ASCVD. And 4 is microbial translocation across gut mucosa reduces inflammation and risk for ASCVD. So single best choice of which one of these is true. Okay. Fantastic. So those are the pretest questions. Now let's get into the core of the talk itself. So first, just what we're going to talk about in general. I like to break it down kind of into what, why, and how. We start with what, which is really what's going on here. What's the epidemiology of HIV-associated cardiovascular diseases? The why is what do we know, what do we think we know, and what do we clearly not yet know about HIV, atherosclerosis, and thrombosis, meaning, atherosclerosis meaning really plaque buildup in the arteries, thrombosis being clotting. Also, what do we know, what do we think, what do we not know about the role of HIV in cardiovascular or cardiac and specifically heart muscle dysfunction and related heart failure? And then the how is how can we best prevent and treat cardiovascular disease in people with HIV with some practical, really relevant points for the care immediately of people with HIV, and then some therapeutic thoughts and insights into what may be coming down the road to help us best prevent and treat heart disease in people with HIV. So first, I'm going to talk about cardiovascular disease epidemiology in people with HIV. And to start, a key point is that clearly the reason we're having this talk is cardiovascular disease is increasingly relevant among people with HIV. And what I want to do first is take a step back and give a bit of a primer on what I'm talking about when I'm talking about cardiovascular disease. I'm a cardiologist by background, so I'm thinking about the heart all the time. But I realize some of the terms we use may not be as broadly used. So when we talk about ASCVD or atherosclerotic cardiovascular diseases, the focus is really mainly vascular. So what we're talking about there are the coronary arteries that run around the outside of the heart, the aorta, the peripheral vessels, basically all the different blood vessels that are carrying blood throughout our body and perfusing or providing with oxygen our various organs. And key terms here are atherosclerosis, which is really generally related to plaque buildup in our pipes, in our arteries, thrombosis, which is clotting, and then of course one of the end stage results of these, which is MI or myocardial infarction, which is generally speaking, I think of myocardial infarction or heart attacks as basically clots that form on top of kind of unstable and ruptured ruptured plaques in the arteries, in the pipes. But separately, we'll also talk about the myocardium. And for that, it's really the heart muscle we're talking about there. And these are, when we talk about that, we're talking about factors that influence the size, the function, the composition of the heart muscle. And these are variable. They can be vascular, for instance, in the setting of heart attacks that can lead to heart muscle cell death and heart failure. It can be infectious causes. It can be toxins, cocaine, methamphetamines, other drugs. And it can be other systemic contributors to heart muscle dysfunction. And here some of the key terms are fibrosis, inflammation or myocarditis, hypertrophy, or excessive cell growth to the point that it actually leads to dysfunction. Systolic dysfunction, which is impaired squeeze of the heart muscle, diastolic dysfunction, impaired relaxation of the heart muscle. And then of course, the clinical manifestation of all of this, which is heart failure. So the reason I go through all this is as kind of a 10,000 foot overview, in HIV, we know a reasonable amount about ASCVD, or atherosclerotic cardiovascular disease, in terms of the likely mechanisms. And we're really in a phase now where a lot of the research is focused on implementation. How do we best screen for, prevent, and treat atherosclerotic cardiovascular diseases in our patients with HIV? Not quite at the same stage in terms of the myocardium and heart failure. There's a little bit more limited data. It's been a bit of a moving target. The nature of heart muscle dysfunction has changed dramatically from the pre-ART era to the early and now modern ART eras. And so there's some epidemiologic studies, but relatively less looking at mechanisms of heart failure in HIV. So now that's kind of the background and sort of some of the key terms I'm going to be talking about from a heart disease standpoint. But now I want to talk about the epidemiology of HIV and cardiovascular disease. And to get there, to begin with, we got to start with the epidemiology of HIV. This is familiar to many of you, but really it's a key incidence and prevalence related question, right? So what's happening is the incidence of people, and so I'll actually bring you to the right side of this first. So new infections is in this red column, which you can hopefully see as I'm bringing the cursor over it. And these are new infections. And what you saw is obviously in the 90s, you saw kind of a peak and then a plateau and downtrend to about 2 million or so new infections in the world each year. So incidence of new infections of HIV has stabilized to slightly slightly downtrended. But by the same token, what's downtrended even more, and now I'm going to bring you over to this blue line, is deaths from HIV/AIDS. And so what we see is the incidence of new infections in many ways is actually outpacing the deaths due to HIV/AIDS, which in general, lower death rate is good. But what that means is our prevalence, or our the number of people at any given point living with HIV continues to increase. And that's in the green line here. This is times 10. So, more in the 35 to 40 million range of estimated people living with HIV right now worldwide. So what does this mean for cardiovascular diseases? If you're dying less from end-stage HIV/AIDS related complications, fewer opportunistic infections, et cetera, well, your competing risks for death from other causes are higher. And in particular, if HIV itself and chronic HIV is associated with higher cardiovascular risk as it is. So what we see here, the y-axis is basically proportionate mortality. So the proportion of people with a given condition dying from cardiovascular disease. And the x-axis is years. So basically what we're seeing here is for the general population in green, and for people with inflammatory polyarthropathies in blue, the proportion of deaths among people with those conditions that are due to cardiovascular disease has declined by about a quarter over the past 15 to 20 years. Whereas in HIV, it's increased by about 2 to 3-fold over the same period of time. So that's to say, cardiovascular diseases are an increasingly common, increasingly important cause of morbidity and in this case, mortality for people with HIV. So let's talk through this question real quick. And this is an audience response question, which is, how does the risk for myocardial infarction or heart attack compare for people with HIV versus people without HIV? Option number 1 is it's the same. Option number 2 is the risk is 10 to 20% lower for people with HIV. Number 3 is the risk is 10 to 20% higher for people with HIV. Number 4 is it's about 50 to 100% higher for people with HIV. And number 5 is it's about 200+% higher for people with HIV. So please choose the single best answer and we'll give you a second. All right, and Jose, just to make sure, I believe I am allowed to discuss the results of this question with everyone, right?
Yes, that is correct.
Great. So the most common responses were 3 and 4. which is 10 to 20% higher for people with HIV versus 50 to 100% higher for people with HIV. And again, from the standpoint of a hazard ratio or odds ratio, that we're talking about 1.1 to 1.2 fold higher for people with HIV is the 10 to 20% versus 1.5 to 2-fold higher risk for people with HIV, which is the 50 to 100%. And actually, as you'll see in the coming slides, it's number 4. Generally speaking, the largest epidemiologic data, including in the modern ART era, show that people with HIV have closer to a 1.5 to 2-fold higher risk for myocardial infarction or heart attack compared with people without HIV. So one example of that is here. This is actually an early study taken mainly from the early ART era, looking in the partners cohort in Boston. And what they did is they pretty simply looked at rates of myocardial infarction across different age ranges for people with HIV in blue versus people without HIV, matched controls without HIV in green. And what they found pretty consistently is that people with HIV had about a 1.5 to 2-fold higher risk for rate of myocardial infarction, even after adjustment for key comorbidities. And that was mirrored in a totally different cohort. So this is the VAX cohort, so veterans aging cohort study, looking at tens of thousands of veterans with HIV as well as matched controls. And again, here what they observed, looking at people, this is the y-axis is the rate of acute MI or myocardial infarction, and the x-axis is just different risk factor strata. So these are people who don't have all the way on the left, it's people who don't have hypertension or diabetes or anything like that. For this is, the next is 1 or more risk factors not optimal, but then as you go all the way to the right, it's 3+ major risk factors. So all the way to the right is people with hypertension, diabetes, hyperlipidemia, smoking, for instance. And what you see is consistently, people with HIV have higher rates of acute MI. And this really was the case for people, certainly people who had a detectable HIV viral load and who had significant immune progression marked by a low CD4 count, had about 1.7, 1.8, 1.9-fold higher adjusted rates of MI compared with controls without HIV. But even you still see for people who had viral load suppression and for people who did not have severely reduced CD4 counts, they still had about a 1.4-fold higher risk for MI compared with people without HIV. Again, these are all adjusted for age, sex, race, ethnicity, hypertension, key cardiovascular risk factors, certain behavioral risk factors, substance use like cocaine and alcohol. And there have been a number of other studies that have also demonstrated a clear gradient, which is to say, the worse your HIV control is, both in terms of viremia and in terms of immune progression, the relatively higher your risk for these cardiovascular complications gets. This has also been mirrored to some extent in looking at stroke risk among people with HIV. This is another study from the partners cohort that observed among most age groups, and certainly overall, people with HIV had about a 1.4-fold adjusted higher risk for incident stroke than people without HIV. These are data that, I know I mentioned earlier, historically there has not been as much data on HIV and heart failure. That's something that's really becoming an emerging field as we know more and more people with HIV who have heart failure. So this is from a study within our hospital system here at Northwestern, where what we did is we actually manually adjudicated heart failure events blinded to HIV status to the extent possible, and looked to see, basically used a standardized protocol to see, okay, not only based on administrative codes and lab biomarkers, but also on symptoms, physician diagnosis, objective imaging findings consistent with heart failure. That was how we actually defined incident heart failure events. And then what we did is we compared people without HIV in red to people with HIV. And this graph is actually the probability of heart failure survival. So the lower graph indicates lower heart failure free survival, AKA higher heart failure events. So what you see is fewer people with HIV are continuing to have heart failure free survival pretty consistently throughout this 10 or so years of follow-up. And what that led to is actually a hazard ratio of 2.1 in terms of a risk for adjudicated heart failure for people with HIV compared with people without HIV. And again, as with myocardial infarction or heart attack, we see this gradient where the higher the viral load among people with HIV, the higher the risk for an adverse cardiovascular event, in this case, heart failure. And again, the lower the CD4 count, the higher the risk. In this case, we're saying per 100 cells per millimeter cubed higher CD4 count. So the less CD4 decline, the lower the risk for heart failure, of which the converse is the lower your CD4 count, the higher the risk. These findings were similar in the veterans aging cohort study as well. And what's interesting here too is not only are people with HIV at higher risk for heart failure than people without HIV, but their survival free of heart failure hospitalization after diagnosis is also worse. So here again, a similar graph where people with HIV in red, people without HIV in blue, and you see lower survival free of heart failure hospitalization for people with HIV in red compared with people without HIV shown here in blue. More recent data that are also of interest and I think really get to the scope and severity of some of these cardiovascular complications among people with HIV is some recent data that came out related to sudden cardiac death in HIV. And this is the senior author on it was Priscilla Hsu, a close colleague of mine who's done really wonderful work in this space for almost 20 years now. And so what they did here is they looked at people who are really people who passed away and had autopsies at the San Francisco Medical Examiner office. And what they did is they looked for who had sudden cardiac death that was either presumed, meaning someone, for instance, dying in the field without clear confirmation that it was sudden cardiac death, but a presumption based on underlying risk factors, based on the way the death happened, that it was indeed sudden cardiac death. And that's the overall bars. But then the kind of diagonal line within each bar is the proportion that were actually confirmed with the medical examiner's office to be sudden cardiac death. And what you see is in terms of incidence rates of sudden cardiac death across all these different strata, that people with HIV, which is the left bar of each of these paired bars, pretty consistently had substantially higher incidence of sudden cardiac death than people without HIV, both overall, among women, among men. These are generally were cisgender women, cisgender men. I don't believe that they were able to delineate further gender granularity, at least for this analysis, but that will be an area of further interest for sure. But also looking separately by race and ethnicity groups, fairly consistently, or at least where there were events among people with HIV, fairly consistently higher rates of sudden cardiac death among people with HIV compared with controls. So that's kind of the framework. That's the epidemiology and the scope of cardiovascular disease in HIV. And really what that does, it essentially sets up, okay, this is an important question, something we need to better understand and be able to treat. But so the question is, why is this all going on? And this is where I really want to dive into some of the core mechanisms of HIV-associated cardiovascular disease and discuss why this is particularly relevant for HIV. First, I want to talk about inflammation in general. We know in cardiovascular disease, inflammation is a core determinant of whether someone begins to have kind of early stages of cardiovascular disease and whether that pathology progresses. And this is, I think, of a really nice figure that applies to a number of different cardiovascular pathogenic mechanisms. In this case, generally thinking about the myocardium here. And what happens is you have the normal substrate to begin with, and then you get some initial insult or injury that leads to inflammation. Initially, that's good. You want, and as it shows here, you need to inflame to begin to repair tissue. But you also need to be able to resolve that inflammation and clear some of the inflammatory infiltrate so that, maybe in this reversible stage, you can actually have a more appropriately adaptive response. But as time goes on, if the inflammation remains, if it's not cleared, if it becomes kind of maladaptive, that's where you get irreversible pathologic adaptation, tissue destruction, harm, and a lot of these downstream or end-stage cardiovascular complications. And this is a way I like to think of it in general. I think it's very applicable for HIV, and it's this is, I would say, in the cardiology area, we don't always think of inflammation in a kind of granular and sort of a disaggregated way. I think that, with a lot of the people on this webinar, a lot of you probably do, because you're thinking a little bit more about infections and immune responses. But in general, you start with antigens and antigen-like triggers, which can be infectious, but they can also be non-infectious. ApoB, the lipoprotein on which a lot of LDL is carried, low-density lipoprotein cholesterol, is carried and traffics throughout the body and into the lining of the plaque, is a particularly antigenic substance, even though it's not an infectious antigen in the way that we classically think of antigens. So you get these antigens and antigen-like triggers, but then you get an immune response to it. And it's really substantial immune cell activation and biasing, which can drive some phenotype switching. And ultimately, it's really this balance between inflammation, for which some key effectors include monocytes, monocyte-derived macrophages, certain types of CD4 positive T cells, but also effector T cells, CD8 positive T cells. So really how that inflammatory response is counterbalanced by generally a subsequent inflammation resolving response, for which key effectors include T regulatory cells, resident macrophages, et cetera. And it's really the balance between these factors that helps determine cardiac and vascular inflammation, as well as overt cardiovascular diseases. And again, here the balance and timing is critical. You need some inflammation in response to a stressor, whether that's an infectious stressor, some other sort of tissue injury or anything like that. But you also need to be able to clear that inflammation so it doesn't become persistent and unresolving, and ultimately lead to a loss of self-tolerance and potentially autoreactive features of the inflammation. So thinking about infectious antigens, this is it's essentially a drawing I put together on PowerPoint, which you can tell because it looks like it was made in about 1998. But I think the core meaning here hopefully stays the same. So this is really a conceptual model, just thinking about the magnitude and duration of a cellular immune response following various infections, and thinking about it in terms of acute versus a more chronic infection and immune response. And certainly with common viral URIs and colds, you get some degree of cellular immune response and then sort of resolves itself pretty quickly. Flu lasts a little longer. SARS-CoV-2 seems to last a little bit longer. Obviously, this is not, I'm not getting granular into various variants that probably follow their own unique trajectories of magnitude and duration of cellular immune response. But then you're talking here about a little more chronic infection. So HIV, you can have an acute and pretty profound cellular immune response. But then with suppression, a more toned down chronic, still some chronic cellular immune response, but less substantial, with the exception of occasional blips. And then, of course, more latent infections, thinking about CMV when not reactivated, and latent TB, with kind of a low level of a cellular immune response that's generally chronic, and except for in specific situations and immunosuppression may not be reactivated. So, what does this mean? How do we apply this thinking to how we think about cardiovascular diseases? And the background of this slide, I think, is less important than I wanted, and which is why I kind of whited it out, and really putting in the foreground of the slide and thinking about how does cardiac tissue damage happen in the setting of both more direct and more indirect losses of self-tolerance and potential autoimmunity. So from a direct standpoint, what we're talking about there is if you have a specific infection A classical one being streptococcal infection leading to rheumatic heart disease. So what happens there is you get this profound response to the infectious antigens, but that response remains, and you get some mistargeting of self, some crossover recognition of not only the infectious epitopes, but also self-epitopes, and you get tissue destruction. And that's really our classical cardiovascular example of molecular mimicry, where you get this infection triggered, but ultimately autoimmune destruction of cardiac tissue, particularly focused on valves and mitral valves in particular. So that's a more direct, in many ways, autoantibody driven infection, inflammation, autoinflammation mediated version of cardiovascular disease. But there's also more indirect ones, which entail acute and chronic activation, perhaps an exhaustion of inflammation regulating compartments that are really important for self-tolerance, and as a result, a bias towards more persistently pro-inflammatory, both innate as well as adaptive immune responses. And this is something we see in HIV, but we also see it in other chronic infectious and inflammatory conditions. So what does this all mean specific to HIV? And one, I'd say this is a great slide. It's now almost 10 years old, but I still think quite relevant, by Steve Deeks. And what's happening is in HIV, fundamentally, you do get a loss of some regulatory immunity, and that combined with both HIV replication, but also co-infection with other pathogens, microbial translocation, further increasing a pathogenic load. And then, other factors as well, like traditional risk factors, metabolic dysfunction, some of it ART mediated, all can contribute to substantial, biasing away from regulatory immunity and a bias towards a more persistent inflammatory and effector response, marked by monocyte activation of certain T cells, but particularly not activation of more regulatory T cells, endothelial adhesion, coagulation, all driving tissue damage. And in this case, our focus is cardiovascular. So this is a very busy slide, but reassuringly, I'm going to stay on this for a while because I'm going to talk about different pieces of this slide that kind of get to some of the granular components of immune activation despite viral suppression in HIV. So this is a wonderful slide from a great review article that again, my colleague Priscilla wrote, that I think gives a really nice overview of some of the mechanisms of HIV-associated cardiovascular disease pathogenesis. And what you have, key elements here are obviously HIV-related deficiency of certain immune compartments, but also vulnerability to viral reactivation as a result. Microbial translocation, increasing pathogenic load, but also contribution of traditional risk factors, particularly smoking, that are common among people with HIV, all of which can contribute to chronic activation of both innate and adaptive immune compartments, inflammation, and some of these components of ASCVD, including lipid abnormalities, endothelial dysfunction, endothelial permeability to further lipid migration into the plaque, but also thrombosis and vulnerability to clotting, particularly on unstable plaque. So just to talk about a few of these components and some of the studies we and others have done on this, certainly with innate and adaptive immune activation, thinking kind of from a translational epidemiology standpoint, you'd like to see if we're saying, okay, innate and adaptive, kind of immune biases away from what we think of as a more regulatory immunity and perhaps towards a more harmful effector-driven immune response, that should be reflected in our epidemiology. And what we do certainly is we see lower CD4 counts, lower CD4 to CD8 ratios, which are, again, not perfect, but proxy markers of this kind of immune bias away from perhaps this more regulatory immunity. We see those pretty consistently associated with higher myocardial infarction and heart failure risk among people with HIV, but we also see it associated with subclinical disease among people with HIV. We see In terms of thinking about, I talked earlier through kind of the epidemiology of the actual clinical manifestations of disease, like myocardial infarction and stroke. And again, to have kind of from a translational epidemiology standpoint to think, okay, I really believe the biologic plausibility here. You would want to see that there are also clear differences in kind of subclinical, in intermediate markers of these cardiovascular manifestations in people with HIV. And indeed, we do see this. We see that people with HIV have substantially higher risks and rates of non-calcified high-risk plaque. And this has been shown now in probably 20 plus different studies. And you also see that traditional risk factor synergies kind of go along with these HIV-related immune factors to drive an increased cardiovascular disease risk. A couple of other points, there's now increasingly data from humans too, showing that increased metabolites derived from microbial translocation are actually associated with increased risk for harmful clinical outcomes, including myocardial infarction in people with HIV. So thinking about that then, we've talked a lot about HIV-related inflammation. The question then is, what about meds? Do they make things better? Do they make things worse? Suffice it to say they make things better. In general, regardless of the med, ART is better than no ART in people with HIV rather. This was shown in the SMART trial initially over 15 years ago, where they observed that people randomized to interrupted ART had an almost double the rate of MI or myocardial infarction compared with people who had uninterrupted or continuous ART. Now, thinking a little more granularly about the specific antiretroviral regimens, they're not all created equally. So in general, if the comparison is, should I be on ART versus should I not be on an ART? Of course, it's I should be on ART, both from an HIV standpoint, but also from a cardiovascular risk standpoint. Getting a little more granular, the risks for cardiovascular disease among specific antiretrovirals, there are probably some subtle differences here. This includes even starting from earlier on protease inhibitors, where there's not really necessarily a class effect. Ritonavir-boosted darunavir has been associated with a heightened cardiovascular disease risk, whereas ritonavir-boosted atazanavir has actually been associated with a neutral to perhaps even slightly decreased risk for cardiovascular diseases. For NRTIs, this is a bit of a moving target. Some of the older ones did have some mitochondrial toxicity that was associated with some degree of myopathy as well as neuropathy. Whereas for newer ones, the toxicities have changed a little bit. For TDF, nephrotoxicity being a common complaint. For abacavir, cardiomyopathy being seen somewhat more frequently than alternative regimens. And then for thinking about TAF versus TDF, some observations of increased cholesterol levels, particularly LDL or bad cholesterol levels, although there's less clear what the actual effect on cardiovascular disease is for TAF versus TDF, for instance. Circling back to abacavir, it's an important and popular area of discussion where they certainly in some of the longer term follow-up cohorts, there's been an increased cardiovascular disease risk for abacavir versus non-abacavir containing regimens. A lot of questions still regarding the precise mechanisms, some thought to relate to endothelial dysfunction, vascular inflammation, perhaps platelet reactivity. However, it's worth noting that in some of the shorter term clinical trials, there hasn't really been a significant effect on cardiovascular risk in abacavir. So, suffice it to say, how do I personally interpret that? And how do some of my cardiology or how do my HIV and cardiology colleagues, people I know, around the country and around the world involved in the cardiovascular care of people with HIV, how do we all interpret these findings? Is to say, if there's a reasonable alternative to abacavir, it may be less risky from a cardiovascular standpoint. But again, there's still enough conflict in the data that it's hard to say 100% that that's the case. In terms of integrase inhibitors, we still don't really know about cardiovascular risk. It seems, generally speaking, to be approximately equal to perhaps a little bit decreased compared with alternatives, but there is the integrase inhibitor associated weight gain. So the longer term cardiovascular effects of that, I still think are an open question. Let me just quickly answer a question from Ernesto, which is to say, what is the best tool or equation to calculate cardiovascular risk of people with HIV? And can we use it to calculate risk at baseline and once a patient starts ART? Absolutely. I'll get to it in a second. I think I'll get to it shortly. I promise I will. It's probably in the next 5 slides, and I'll be getting into it in a lot of detail. Okay, so another question, another more just evidence to say, with the question being, is it just the meds, or to what extent is it the meds? I think further validation of that kind of mechanistically is this is some interesting data from about 12 years ago, comparing elite controllers, people with HIV who are elite controllers, not on meds, to people without HIV. And pretty consistently, even after adjustment for meaningful covariates, their carotid intimate media thickness, which is a marker of arterial pathology and injury, was higher among elite controllers with HIV than people without HIV. Hypertension was more common as well. And even when they restricted it to these elite controllers with CD4 counts above 500, even they had higher carotid IMT, or again, a marker of arterial injury or pathology, compared with people without HIV. So now thinking mechanistically about HIV-related heart failure. For the purpose of this talk, I'm focusing mostly on, and especially in our final slides and some of our final discussion, I really want to be practical in my focus. So I'm not going to get into too much detail into these various mechanisms that we're investigating. But I do want to highlight, we go into this in a lot more detail in our scientific statement, which we put together with the American Heart Association, involving a number of HIV care providers. It actually involved a patient with HIV who was a co-author with us on that statement as well, to make sure that we really had full multidisciplinary input on it. So this is discussed in more detail in that statement, which I definitely encourage you to check out. It gets to some of the risk questions as well. But what I'll say here briefly is mechanisms of heart failure and HIV. There are a lot of potential mechanisms. We still haven't fully defined every one of these all that granularly. And this is important. This is going to be important to do in the coming years to really help define where are our targets for prevention, where are our targets for intervention. So for people with HIV, whether it's acute or in most cases what we're talking about chronic, we know, like we've talked about, some degree of vascular stiffness and endothelial dysfunction, certainly inflammation, some inflammatory dysregulation, some predilection for thrombosis and dyslipidemia, all of which can certainly drive ischemic heart disease. So heart disease related to the coronary arteries that run around the outside of the heart muscle, but also even of the microvascular, these kind of little branches, these little side streets that dive down off of the highways of the coronary artery, all of which can contribute to impaired relaxation, impaired heart muscle function, and heart failure. But there's also factors that can lead to more direct toxic damage to the myocardium, as well as disease of the valves, again, which can lead to fibrosis and scar, obstruction, whether of the valves, whether within the heart muscle itself, all of which can impair cardiac output, can lead to impaired heart relaxation, impaired heart squeeze, and then heart failure. So lots of mechanisms here, a lot that still need definition, and certainly, unfortunately, something that will continue to be more and more common among people with HIV, given all of these combining and really, unfortunately, synergistic in a bad way, comorbidities ranging from metabolic dysregulation, obesity, to various chronic stressors, whether physiologic like smoking, or even psychosocial stressors that can drive chronic systemic stress as well, and ultimately drive cardiac dysfunction. So here are the practical slides, what I think are the most practical slides, rather, that I promised we'd get to in these last 10 or 15 minutes. So how do we think about preventing and treating cardiovascular diseases among people with HIV? But first, let's do this audience response slide. The question is, when assessing risk for cardiovascular disease in a patient with HIV, which of these strategies do you most commonly use? One is the Framingham risk equation. And by the way, no right answer here. This is actually just a question. Framingham risk equations, which are for coronary heart disease or total CVD, the ACC-AHA AS-CVD risk estimator, also known as the pooled cohort equations. That was number 2. Number 3 is the DAD risk equations. Number 4 is I don't use any of these, but I use my clinical judgment based on what risk factor levels are. And number 5 is none. I don't really qualitatively assess CVD risk. So I'll give everyone a second. And while you're doing that, I actually have to just run and go to refill my water. I will be back in truly 1 minute while this question's hanging out there. Okay, so let's see what we have. Okay, most of you are using the ACC-AHA AS-CVD risk estimator. I tend to use that as well. I think the interface for that is probably the best. Unfortunately, it's a mouthful, although I guess the pooled cohort equations are how some people refer to it. But yeah, I tend to use that for reasons that I'll get to in a little bit. But I think most importantly is to just be able to think in some way about the cardiovascular risk of your patients, because a lot of these do use similar enough inputs. So I want to talk a little bit about cardiovascular disease risk scoring and why we use it. And the key here is we use it so that we can inform kind of a high-risk strategy for prevention and basically identify the individuals at highest risk so we can match the intensity of our intervention to prevent cardiovascular disease to their degree of risk. So I think a broad way to think about this in epidemiologic terms is the population strategy versus the high-risk strategy. So a population strategy, the idea here is if we're looking at the risk for a particular condition across a population, and let's say in bell curve A, that's curve A is really the risk across a population. Let's say we're talking about lung cancer and smoking. So this is what the risk is of lung cancer across the population by doing certain types of policy interventions, for instance, indoor smoking bans, et cetera. The goal there is you're not focusing on one population in specific, you're trying to decrease the entire population's exposure to cigarette smoke and therefore move the entire, the health of the entire population over here to the left. This is essential and an essential backdrop to public health. But as physicians, a lot of what we do is the bottom one. which is the high risk strategy. And in that case, the idea is we look to identify people at the highest risk, so more in this case towards the right of the curve in terms of risk, so that we can then say, okay, these are the people at highest risk. These are the people in whom the relative benefit of an intensive intervention may outweigh whatever the risk is of the intervention. So we need to treat them really aggressively. So a couple more points here in terms of how I think about risk scoring and such is thinking about absolute risk versus relative risk and why it all matters. So a perfect example of this is statins. So atorvastatin, rosuvastatin, common medications that lower cholesterol, but also across most populations studied, reduce risk of heart attack and stroke by about a third. By the way, we're still waiting really large scale HIV trial data in this, which we'll get to in a second. But for why absolute risk matters is these are practical examples I see in clinic. Again, I'm a cardiologist, but about 30 or 40% of the patients I see in clinic have HIV. So let's take a 55-year-old who, let's say, we look at their cardiovascular risk factors, and based on those, we detect, okay, they've got about a 3% risk of a heart attack or stroke in the next 10 years. And we know, okay, if statins reduce it in relative terms by about a third, that means the absolute reduction in risk goes from, let's say, 3% to 2%. So it's about a 1 in 100 reduction in risk of heart attack or stroke in the next 10 years. It's something, but it's not huge. Meanwhile, let's say there's a 55-year-old who has diabetes, hypertension, who's smoking, and they, based on those factors, for instance, have about a 30% risk, let's say, of heart attack or stroke in the next 10 years. And we know a statin, again, it's reducing it by about a third, but instead of going from 3% to 2%, you're going from 30% to 20%. So what that's saying is you're getting an absolute risk reduction of about 10%, or in other words, a 1 in 10 chance that by taking this pill, you're going to not have a heart attack or stroke in the next 10 years that you otherwise would have if you weren't taking the pill. That's pretty substantial. And so this is why we think about absolute risk, and we use risk scoring to get us to think about absolute risk. A couple points. This is, we looked here, this is in the CNIX cohort, where we looked at how well do the ACC-AHA ASCVD risk estimators work in CNIX. Actually, in white men, worked reasonably well. Each dot is basically per decile of patients, so per several hundred patients, whether the observed risk on the y-axis corresponded to the predicted risk on the x-axis. And so the closer to the line, the more one-to-one, meaning someone had a 10% predicted risk of heart disease and stroke, they had a 10% observed risk as well. What we found is, particularly among Black participants in CNIX, substantial underestimation of myocardial infarction risk. And this is from the ACC-AHA risk estimator, which actually incorporated, generally speaking, a more diverse population than others like the Framingham risk estimator has. So what we see here is fairly consistent underestimation of risk, meaning people with HIV have a higher than predicted risk. And then subsequently, a colleague, Jeannie Triant, and her group looked at a number of other risk calculators, including the Framingham ASCVD risk estimator. And likewise, what they found is here, per decile of risk, looking at the observed risk in red versus the predicted risk in blue, pretty consistently, the actual atherosclerotic cardiovascular disease risk, so heart attack and stroke primarily, heart attack and ischemic stroke primarily, those risks were substantially higher than what would be predicted among people with HIV. So the takeaways here are that people with HIV have consistently higher atherosclerotic cardiovascular disease risk than what one might expect based on our risk calculators. What can we do about it? So let's say in the general population, we've got this mass of high quality statin trial evidence, quite a bit less in the population without HIV. That number is growing a bit because of Reprieve, which many of you know about, but many thousand, I believe they're up to, I want to say, over 7,500 enrollees, and they're randomizing people with HIV more in the low to moderate risk for cardiovascular disease range or they have randomized, I should say, to kind of a modest intensity statin to evaluate whether it effectively prevents heart attack and stroke in them. And they're also doing a number of very interesting sub-studies that'll give us important mechanistic or semi-mechanistic information in the coming years. So the question is, what is our interim approach in the meantime to thinking about ASCVD risk? This is a slide, I believe it's figure 4 from our AHA, from our American Heart Association scientific statement, and it goes into this in detail. But just to walk you through it briefly, the general idea of how based on available data, some of the epidemiologic and mechanistic data I've shared, and some of the treatment-related data I've shared, how we think about cardiovascular disease risk prevention and treatment in HIV. So the key here is, first, sorry about that, starting with, okay, are you really in a population that we have enough data, that we've had enough data to study? So assuming so, and assuming you don't have an obvious reason to already be on intensive cholesterol lowering therapy, like prior heart attack, stroke, known peripheral artery disease, familial hypercholesterolemia, such as an LDL cholesterol level of 190 or greater, diabetes. These are all clear first-line indications for statin therapy already. But absent that, really then thinking about assessing your ASCVD risk. But then the next question is, how do we really interpret that in an HIV-specific way in thinking about what is the relative increase in the number you get? So let's say you have HIV, we plug your numbers into the ASCVD risk estimator, and we get 8%. What does that mean? So, well, what we do then is think about, are there any HIV-related cardiovascular disease risk-enhancing factors, like history of prolonged viremia, low current or nadir CD4, metabolic syndrome, certain co-infections, factors that among people with HIV have been associated with particularly elevated risk? And if so, then in general, I would think of that as almost a 1.5 to 2-fold multiplier of the predicted ASCVD risk. So let's say you have a number of these risk enhancing factors, you have HIV, you plug your numbers into the ASCVD risk estimator, you get an 8% 10-year risk. In reality, are you closer to a 12 to 16% 10-year risk? I think probably, based on the available data. So then what do we do about it? For those at higher risk, those for 7 to 10% risk for heart disease and stroke in the next 10 years and higher, certainly consider a referral to cardiologist. I enjoy seeing people with HIV. Increasingly, I think cardiologists are understanding that this is an important area and an important population that's only going to grow in their cardiovascular needs in the coming years. But certainly, lifestyle optimization for everyone at their core, particularly smoking cessation, but also lipid lowering therapy. And I would say with statins, even though it's not grammatically correct, start low, go slow, which the idea being start at kind of a lower dose of some of these statins, and you can up titrate gradually, knowing that in general, the risk, particularly with some of the newer statins like rosuvastatin, atorvastatin, pitavastatin, the risk of severe side effects, particularly ones that might lead to hospitalization or anything, are exceedingly low. And there are a number of parameters that we talk about that would lead one to discontinue that. And one additional point, I would say, avoid simvastatin. That's an older medication, tends to have a lot of drug-drug interactions, particularly with the CYP systems. The role of aspirin is not really as clear. So in terms of HIV specifically, we've got some conflicting data that aspirin actually didn't seem to impact markers of immune activation or endothelial function. But again, it was a pretty young study population, short follow-up, and the endpoint of flow-mediated dilation was, maybe not as hard of an endpoint as some other studies. But there's quite limited data on aspirin and HIV. So given all this, despite potential prothrombotic or clot-related risk in HIV, there's not really compelling evidence to have a substantially different approach than in the general population for cardiovascular disease prevention. Heart failure, as I said, studies ongoing. We have a lot to do still to understand the pathogenesis of heart failure in people with HIV. Quite a bit more investigation is needed, but the bottom line is having a high index of suspicion, low threshold to start thinking about cardiovascular complications in our patients with HIV is important. So, now to just get to a couple of conclusions. One is people living with HIV have higher risk for a number of cardiovascular complications, particularly myocardial infarction or MI, particularly heart failure. Generally speaking, from some of our epidemiologic data, 1.5 to 2-fold higher risk for a number of these. A lot of that is driven in part by those with poor viral control and or immune progression. In other words, those 1.5 to 2-fold higher risks may be somewhat muted, but still elevated among people with good viral control who haven't experienced immune progression. Part of the reason is there's still chronic inflammation and immune activation despite effective antiretroviral therapy that all plays a substantial role in cardiovascular disease. And again, we need to be really mindful of all of this in our aging HIV population. So I'm going to get to the last couple of post-test questions. One, again, how does the risk for heart failure among people with HIV compare to people without HIV? One is they're lower among people with HIV. Two is they're about the same. Three is they're about 1.5-fold higher for people with HIV. And 4 is they're about 10-fold higher for people with HIV. And I believe I'm actually allowed to read your responses afterwards and let you know what's correct. Jose, correct me if I'm wrong on that one.
Yes, that's correct, Dr. Feinstein. Thank you.
All right. So everyone's on board with heart failure being more common. Almost everyone's on board with heart failure being more common among people with HIV. Over 4/5 of you said they're 1.5-fold higher, which is true. That's the correct answer. And some said they're about 10-fold higher for people with HIV. Fortunately, no, not that severely elevated, but still about 1.5 to 2-fold higher. The next question is which of the following is true regarding the immunopathogenesis of HIV-related ASCVD? 1, residual immune activation despite effective ART is implicated in HIV-related ASCVD. 2, co-infection and viral reactivation can trigger inflammation but do not play important roles in HIV-related cardiovascular disease. 3, traditional ASCVD risk factors like hypertension and smoking are not important contributors to ASCVD risk in HIV. And 4, microbial translocation across mucosa reduces inflammation and risk for cardiovascular disease. Okay, and the answer was, wow, 96% said 1. Okay, that's correct. You all got it pretty well. Correct. Residual immune activation, even despite effective viral suppression, is implicated in cardiovascular disease pathogenesis. Okay, so that is really it. And I can get to some of the Q&A now. This is my email contact information. My Twitter is pretty simple, at Matt Feinstein, MD. And I can leave these up as we chat, unless you prefer me to take the slides down, Jose and IAS folks.
Yes, Dr. Feinstein, you could unshare your screen.
Okay, great.
All right, and you may view the questions using the Q&A button.
Great. Okay, I'll just go in order here. So Ernesto, the question about the best equation to calculate risk. I didn't say this explicitly in my conversation, but the reality is most of them, so whether it's the ASCVD risk estimator, whether it's the Framingham risk score, whether it is the DAD risk estimator even, they use largely similar inputs. They're still looking at key cardiovascular risk factors. So they get largely concordant risk estimates. But based on, for me, I think the DAD, while it's HIV specific, tends to be more European and Australian in terms of its derivation population. Framingham also largely, white to a greater extent than the ASCVD risk estimator. So I do think the source population for the ASCVD risk estimator is probably what drives me to use it the most. But again, they have to be taken with a grain of salt. So when I have someone with HIV who's, let's say they were infected 5 years ago, diagnosed immediately after infection, well controlled on ART since then, no immune progression, CD4 count 1,000, let's say. So for that person, their risk is probably not that much higher than what you would see from the ASCVD risk estimator, just because you don't have those HIV-related risk enhancing factors. Whereas someone who's had a history of prolonged viremia, some degree of immune progression, that's where you'd think, okay, I'll do the ASCVD risk estimator, but then think we're probably talking about a 1.5-fold multiplier there. Good question from Paul McHugh. Do you have a favorite statin to start with patients that are also pre-diabetic, and some information about statins and diabetes? So yeah, that's an important point to cover. So statins can lead to some degree of insulin resistance. What I will say is it's limited, probably not as much as, from a practical standpoint. Really what happened is it's not like statins took people that had no insulin resistance and suddenly make them diabetic. But there are, statins in general as a class, but particularly even rosuvastatin, for about, what they've found is that if someone is kind of pre-diabetic and near the borderline of actually officially being considered to have diabetes from an hemoglobin A1C standpoint, statins accelerate how you get there by about 4 to 6 weeks. Not really dramatic, but it still is something. So for them, I'd probably use atorvastatin rather than rosuvastatin. Those are our two highest intensity statins. The highest dose for atorvastatin is 80 milligrams. And often I'll start people at 10 milligrams and just gradually up titrate. Rosuvastatin, the highest dose is 40 milligrams. And I'll often start people at 5 or 10 milligrams and up titrate. Question related to any increased incidence of valvular disease among people with extensive ART exposure? It's a really good question. It's really hard to delineate, at least at this point, because some of it depends on the comparison population, but also some of it depends on, are we looking at clinically significant valvular disease? So severe valvular disease, stenosis, regurgitation, that's more than just trivial or mild and incidentally noted. The tough part is those are somewhat rare, and somewhat confounded. If there's extensive co-infection, if there's IV drug use, which can lead to endocarditis and/or can lead to serial deposition on the valves over time, leading to valve dysfunction and fibrosis, that can increase it. I don't have great data on that. I think it's a really good question and one that would be interesting to investigate in the coming years. Accuracy of CAC scoring in people with HIV, not really. I'm trying to think of, to really best determine the accuracy of CAC scoring, you'd need a large prospective HIV cohort. So multi-center AIDS cohort study would be a good one for that. Obviously, it's not looking at all demographics of people with HIV, but they did do regular CT scans. The tough part is you need enough outcomes to really start assessing whether the CAC score is significantly helping reclassify patients. I can see the one downside there might be that people with HIV are particularly likely to have soft and non-calcified plaque. So I'd say a CAC score of 0, so 0 coronary calcium, is not necessarily a reassuring sign, because you still could have soft and non-calcified plaque with HIV. So I don't use it all that often with people with HIV, but I don't think we have great epidemiologic data, HIV specifically here. Great question by Emily Jansen on recommendations or resources for evaluating response to statins after initiation. I usually wait at least 8 to 12 weeks after the statin to check a lipid panel, and that's the primary way I look for a response. After that, once you're at a steady state, it's, I think it's helpful to get yearly or every other year lipid panels, just from the standpoint of kind of keeping the patients honest and accountability for themselves. Because if they are, more intermittently taking a statin, and then they see, okay, my LDL was 100, now it's 50, or well, it was 100, got down to 50, but now it's back up to 70, and I know I haven't really been taking it as often. That's kind of a nice accountability feature there. For the moderators, I've finished everything on top of Volkan Kortin's question. And Volkan's question is, what is your high risk threshold for ASCVD? Is it 7.5 to 15% or 20%? Practically speaking, in the 7.5 to 10% range, I'm kind of thinking moderate to high risk. In general, I think they've previously called 5 to 10% moderate risk, high risk, more in the 10% range, 10% plus, very high risk, 20% or above. But based on some of the risk benefit trade-off, and obviously this is extrapolating from incomplete data, but I'd be hard pressed. If someone's risk of heart attack or stroke is 10% plus, I'd have to have pretty clear resistance, intolerance of a cholesterol lowering medication to not be convinced that it's probably the best to start. It's still a discussion with each patient. It's because some people are really reluctant to start meds, especially when they're on a number of other ones, and I get that. So of course it's not a force, but it's just saying objectively, if I were you, if you were my family, my friend, I do think the likelihood of the benefit outweighing the risk of starting a statin, once you're at the 7.5 or 10% or so 10-year risk level or higher, it's substantial. Yes, Jim Johnson, very important point. Family history of early ASCVD. Absolutely. By that, we are generally saying, do you have a family history of heart attack, stroke, heart problems in people starting in their 50s, early 60s? And if so, that you probably confers some degree of genetic or semi-genetic risk to the patient. And I talk about that always. I think that's absolutely essential. It's not really considered yet in our risk estimators. It probably should be. The biggest challenge is kind of non-uniform acquisition of that data. But it's another feature to think of, certainly as a risk enhancing feature, where let's say you get this calculation, but someone's got a bunch of heart disease in their family in their 50s, 60s, you may want to bump up their risk. The other thing to do that's worth checking is I often check an LPA or lipoprotein little a, LP little a. That is something that's kind of semi-genetic, tends to run in families, a marker of both lipid abnormalities, but is also kind of prothrombotic in its nature. And what that can do is we know that high LPA increases risk several-fold for heart attack and stroke. So if someone has a really substantial family history like that, first you look for obvious things like familial hypercholesterolemia. Do they come to me, they've got a family history of substantial heart disease and their LDL cholesterol is 200 and their total cholesterol level is 320. That's a phenotype of familial hypercholesterolemia. And whether or not you're genotyping that, as long as they don't have another cause like uncontrolled thyroid disease, for instance, or nephrotic syndrome, then you can pretty much know, okay, it's this really uncontrolled hyperlipidemia that's probably the main cause of this family history. But then you get people who have normal cholesterol levels and come in with substantial family histories. And for them, it's more, that's where I find an LPA to be very valuable, where if it's elevated, so depending on the assay you're using above 30 or above 75, if the LPA is elevated, then that alone is generally enough to think more aggressively about lipid-lowering therapy. Health inequities and social determinants of health contributing to ASCVD risk in people with HIV, absolutely. Most of the work that I and others have done relates to risk factors, because it's a little easier to trace risk factor development from social determinants of health. Diabetes, metabolic syndrome, smoking, but also other concomitant contributors, stress, chronic stress, allostatic load. There's a lot of these factors that people with HIV are particularly at risk for and do contribute to their cardiovascular risk. I don't have a great epidemiologic study or data yet to say to you, this is how much it increases risk, but certainly it's important to be keeping in mind. A question about, do you foresee being able to add HIV-related risk factors to the ASCVD risk calculator in addition, from Lewis at Case Western? Oh, I hope so. You know, I think so. I think it's something we tried. That was the original point of that CNIX paper I did. And I know others have tried it in the partners cohort, which I pointed out afterwards. The reality is you need a lot of data and you need a lot of outcomes, meaning you need a lot of heart attack, stroke, potentially heart failure type of outcomes to really then evaluate how well calibrated your new risk models are and how well they discriminate risk among high risk versus low risk people. So one of the key takeaways for me with that was, even in these big HIV cohorts, we don't have enough event yet to really meaningfully and that dramatically add new markers to our risk estimators. I think 5 years down the road, 10 years down the road, as we continue to have more follow-up for cardiovascular events, I think the accuracy and precision of these estimates will get better, and our ability to really have meaningful, US population-derived ASCVD risk estimators in HIV should improve. Next one from Mary. Have you seen an increase in incidence of patients with cardiovascular complications in HIV post-COVID? Personally, not really. But I think that the answer to that is there probably will be some degree of increase based on just some of the underlying immunologic abnormalities that predisposition towards profound inflammatory responses. But I don't know yet. I haven't seen those data yet. And I think we'll start, my instinct is in the next year or two in a lot of these larger HIV cohort studies, and in particular, if anyone on this call is interested in those, that would be an interesting study to propose that is evaluating incidence of cardiovascular disease in COVID co-infected people with HIV versus people without. Question from Javier about the measurement of inflammatory markers. Do I trust them to stratify patients with unclear risk? To some extent, they're not useless. The tough part about CRP, for instance, is the intra-individual variability over time. So there have been some really cool studies of this where they just measure on the same thousands of people CRP in the year 2004, and they measured it in the year 2005. And you got a ton of people who had CRPs of 8 to 10 in 2005 and less than 2 in 2004, and vice versa. So the ability for that marker to track over time is not great. And so because of that, it can kind of impair how longitudinally predictive it is. Certainly some markers of subclinical disease. CAC is still not useless. Carotid intimate media thickness, probably not useless. Certainly carotid plaque is a useful marker. Whether or not someone has actually clinical peripheral arterial disease, all reasonably helpful. Okay, a question related to CVD from smoking to risk of CVD from HIV. Great question. You know what I'm going to do? This isn't in my talk, but I'm going to find this. Unless Jose, Donna, and all, am I allowed to bring up a figure from a peer-reviewed publication that's not part of my talk that I think is a direct relevant answer to that, or should I just describe it?
Dr. Feinstein, you're welcome to share the slide.
Okay, let me just bring that up for you because I think, you know what? Yeah, here we go. Perfect. This is exactly what I wanted to show. This it is from This is from an article by, let's see, I believe it's Priscilla Shu and David Waters a couple of years back. But let me just share this figure. So this, I think, is a great figure of HIV-associated cardiovascular risk, particularly for ischemic heart disease, compared with that, at least in the InterHeart study. If it's 1.5 to 2.5 fold higher. For smoking, it's maybe 2 to 3 fold higher risk. For severe dyslipidemia, maybe 3 to 4 fold higher risk. Hypertension, more similar. Again, pretty wide confidence intervals here, but the general idea is, yeah, maybe it's reasonable to say that that the HIV-associated increase in cardiovascular risk may be comparable to modest hypertension, modest dyslipidemia. I think that's fair based on the available data to us. Jim Johnson, good question. Patients being treated with testosterone, how much elevated cardiovascular risk might that confer? Depends. So there's a lot of people that use testosterone replacement therapy, and then there's a lot of people that use testosterone replacement therapy, right? Where they really go above and beyond kind of low-level replacement to sort of supraphysiologic levels. What we know in general for testosterone therapy and heart disease is that if you're getting excess testosterone replacement, your risk for heart disease, particularly clotting associated with it, but also some dyslipidemia, is higher. So people using supraphysiologic testosterone replacement, potentially some increased risk there. What I will say is for people with low testosterone, though, significantly low testosterone levels are also associated with increased cardiovascular risk to some degree. So if it's truly replacement and getting you to kind of low normal physiologic range of testosterone, that's reasonable. And I think that's maybe even certainly probably better from an energy standpoint, but may not actually be conferring additional cardiovascular disease risk. And then the last unanswered question I see from Christopher Matthews is how much of the excess MI risk in HIV is due to type 2 MIs? Very good question. Type 1 MIs versus type 2 MIs. And if this is the Christopher Matthews I know, and we've worked with some of the CNIX folks on that, that's a particularly apt question from our CNIX data, but probably some. So type 1 MIs are traditionally what we think of as kind of primary plaque rupture events. Those risks are still higher among people with HIV. And part of why I say that is when different cohorts have used administrative codes in different ways, some that bias more towards focusing on type 1 MI assessment rather than including both type 1 MI and type 2 MI, which is more, less direct plaque rupture, more kind of what's supply-demand mismatch in the setting of other severe illnesses. Anyways, people with HIV are more prone to type 2 MIs. I don't think it's driving all of their excess MI risk. And another thing supporting that is kind of even in the pre-troponin or pre-kind of MI biomarker era that led to more diagnosis of type 2 MIs, there are still consistently higher risks and similarly higher risks for MI among people with HIV. But it may be driving some of the excess risk. So that's a really long way of saying some, but certainly not all, maybe not the majority of excess MI risk. Some very nice comments in the chat. I really appreciate it. It's fun doing this. I'm a cardiologist, but a lot of my focus is here. So I'm happy to chat with you all. If you all, you can get in touch with me. I'll put in the chat my email, my Twitter. Happy to get in touch, talk more, talk to you at your institution, whatever it is. There you go. So I'll give it another minute or so and then let the IAS-USA staff tell me what to do.
Thank you, Dr. Feinstein. And we'll close out this webinar. Again, we'd like to thank you for the excellent presentation and Q&A discussion. As a reminder to our attendees, evaluation and information on how to claim continuing education credits will be made available by 5 p.m. Pacific time tomorrow, and this will enable us to review all of those that have attended today's live broadcast. Here are a list of upcoming webinars. For more information, please visit the IAS-USA website. We have an upcoming course on June 13th titled The Scott Hammer Annual Update on HIV Management in New York, New York. Again, for additional information on our activities, please visit the IAS-USA website. Lastly, we have an upcoming COVID-19 dialogue, which will discuss the latest updates on COVID-19, scheduled for Friday, May 6, 2022. Lastly, again, we'd like to thank our presenter, Dr. Feinstein, and to the audience for your participation. This concludes today's webinar.